Good morning. We want to thank you for joining us today for the PSO Engaging Patients and Visitors in Compliance and Transition-Based Precautions webinar. My name is James Hayes, and I'm the Project Manager for Education Services, and I will be helping to field questions as we move through the webinar. With me today is Shelby Lassiter, Director Clinical Improvement for the NC Healthcare Foundation, who will be providing us with some opening remarks. Also with us today, subject matter expert Evelyn Cook, Associate Director for the Statewide Program for Infection Control and Epidemiology, SPICE. I'd like to review some technical information about the webinar so that you'll know about your control panel and how to move forward. All lines will remain muted throughout the webinar. Questions will be addressed during the question and answer at the end of today's presentation. If you would like to chat in a question at any time during the webinar, you're welcome to do so by using the question pane or the chat pane in your control panel. Please include your organization before posing your question. You may also ask your question live by phone. If you'd like to do so, click the hand icon to raise your hand. We'll acknowledge you. And then before posing your question, if you would, again, repeat your organization and your name so that folks on the line can hear your question. I believe those are the main things. At this time, I'll turn the webinar over to Shelby.
James, thank you. And thank you all for being with us today. We're very excited to be sponsoring this through our patient safety organization. PSO is an organization that collects, aggregates, and analyzes patient safety events, such as healthcare-associated infections. And these are confidentially reported by hospitals and other types of healthcare facilities. And through that reporting, the data are legally protected through the Patient Safety and Quality Improvement Act of 2005. And PSOs also support member organizations in identifying contributing factors, doing root cause analyses, and learning best practices to prevent such events. So we appreciate the Quality Center Patient Safety Organization for sponsoring this webinar today. To find out more about being in the Quality Center PSO, please contact me, and we will provide my email address to you. Without further ado, let me talk about today's webinar is in celebration of International Infection Prevention Week. Every year this time of the year, the International Infection Prevention Week is celebrated starting in 1986, and the focus of this week is on saving lives through preventing infections by educating providers, leaders, and legislators. So what we want you to do today is to listen carefully. Our subject matter expert is a phenomenal infection preventionist with a wide range of knowledge across the healthcare continuum, and you're going to learn a lot today. We want you to share what you hear and pass the information on to others in your organization. So without further ado, let me introduce Evelyn Cook. Evelyn is the Associate Director of the Statewide Program for Infection Control and Epidemiology here in North Carolina. As such, she is a principal lecturer at all of the SPICE infection control courses. She's a consultant to all healthcare facilities across the state, including long-term care facilities, on infection prevention issues. She leads applied research projects in the area of infection control and epidemiology of infectious diseases. And she's assisted long-term care facilities in writing and developing infection prevention risk assessments, prevention plans, and policies specifically to that healthcare setting. Prior to joining SPICE, Evelyn served as nurse clinician and nurse liaison with the Duke Infection Control Outreach Program, or DICON. So with that, I will turn it over to Evelyn. Evelyn, thank you for being with us today.
Shelby and James, thank you so much for that kind invitation to be with you guys. And So for the next 30 minutes or so, we're going to chat about something that I believe is really important and also something that we have, for whatever reason, maybe not considered quite as much as we should. So the topic for today is engaging patients and visitors in compliance with transmission-based precautions. Can we do that? Is it important to do that? And what would that look like if we were able to accomplish it? So I wanted to start out by just recognizing that both of these little slides that you see in front of you are evidence or illustration of how busy we all are. It's a very busy work environment. And I know there have certainly been days that I felt like my head was going to explode because there was so much information overload and so many things that people were asking me to do. And oftentimes, you feel like you're kind of behind your desk and you can't even see you over the pile of papers and the activities that you're responsible for. And all you feel like you can do is just kind of hold up that help sign. And if you're the primary or the bedside nurse and you've tried to educate a family member about precautions and you go into the room and they're sitting on the bed with no gown or gloves, you're very, very frustrated because you have a lot of other activities going on. And then if you're the infection preventionist in that facility, you're also very busy and you're working up an exposure and trying to get your infection rates done. And then all of a sudden, your phone rings and the nurse on the unit says, would you please come up here and talk to this family because they just will not wear their personal protective equipment. So I think we are all very busy and this might be something that's kind of gotten under our radar, but hopefully at the end of the webinar, everyone will recognize the importance and hopefully have some strategies, excuse me, for how that can be implemented. So the outline today is we're going to actually look at the current guidelines as they relate to patients and families. We're also going to talk about what we know about transmission as it relates to healthcare personnel compliance. And then ask ourselves the question, is it important to engage patients and families? Does it make a difference? And then we're going to kind of fast forward from the past guidelines to what some of the current recommendations are related to patients, families, and their visitors. And then hopefully at the end, discuss some steps for plan implementation and some of the actions that we might be able to initiate. So this probably looks familiar to most of the audience. It's the 2007 Guideline for Isolation Precautions. And it was really intended for use by any infection control staff, healthcare epidemiologists, anyone basically that worked in the healthcare setting, including administrators and other healthcare providers. And it addressed all those factors that influence transmission risk within the healthcare setting, also looking at some recommended infection control practices, as well as what the culture of the organization looked like. And also in this guideline, for the first time, they also discussed some surveillance of healthcare-associated infections. So this was a pretty overarching guideline. So let's just think a minute about what it said related to education for not only healthcare workers, but patients and their families. So in the narrative of the guideline, it basically said that it would be good and if we could provide some information about standard precautions, especially hand hygiene, respiratory hygiene, cough etiquette, and other infection prevention strategies may be incorporated into patient information. So it really didn't say we had to, it just said it could be. And that those materials could be things like leaflets and pamphlets and flyers that could be given to the patient and their family, and that the healthcare worker really should be available while that information was reviewed to make sure that they could address or answer any questions. And then they also noted in the narrative that any additional information related to transmission-based precautions was best provided at the time they are initiated, which makes sense. If someone's admitted and they're not placed on isolation for 2 weeks, if we only educate them at time of admission, then most likely they've forgotten all of that by the time that we need to apply those strategies. The one thing that I did find interesting they included in there was a comment that educating patients and families was particularly helpful in the home situation. And hopefully at the end of our discussion, you'll recognize it's very important in the hospital setting as well. So did they say anything about barrier precaution used by visitors? And they did. And basically they noted that it should be based on the amount of activity or the direct contact that the visitor and or the family may have with the patient. And they do note in here that those having very close contact could possibly contribute to the transmission of infection if barrier precautions were not used correctly. And then they kind of summarize that by saying it varies by facility or even by unit, and each one should determine what their policy would be, determined by the level of interaction. So this isolation guideline is probably 300 or so pages long. A lot of that is the narrative, and most of us just go straight to the recommendations at the back of the document. So this is a Category 2 recommendation that from all of that information we saw in the narrative made its way to the recommendations. Basically, to provide instructional materials for patients and visitors on hand hygiene, respiratory hygiene, cough etiquette, and the application of transmission-based precautions. And for those of you that may not be familiar with the category rating, a Category 2 is suggested for implementation and supported by some clinical or epidemiological study or theoretical rationale. So it wasn't, a really uber strong recommendation, but it did make its way into the recommendation section. So is there any other document out there from CDC that speaks to education? Well, there is. It's the Core Infection Prevention and Control Practices for Healthcare Delivery in All Settings, for safe healthcare delivery in all settings. That was disseminated by HICPAC, or the Healthcare Infection Control Practices Advisory Committee. And in their document, they also note that you should provide infection prevention as appropriate to patients, family members, and visitors, and anyone else that's included in that person's caregiving network. And they're a little bit more specific about saying that we should provide information related to how infections are spread, how they can be prevented, and what signs or symptoms might prompt reevaluation by the provider. So they're very clear about the education piece. However, they do not mention anything specific related to transmission-based precautions or use of barriers by family members or visitors. So let's just refresh real quickly a little bit about what we know related to compliance issues in healthcare settings. And most of the studies, as everyone knows, has been done related to healthcare workers or healthcare personnel. And in the studies that the CDC hand hygiene guidelines referenced, they reported in an aggregate format of 34 studies. Hand hygiene compliance was reported to be at an average of about 40%, which we can all agree is much less than adequate. And you see and are familiar with the reasons that personnel cited for not being compliant with hand hygiene. And then there's been some observational studies that looked at the duration or the adequacy of hand hygiene. And what they found is that on an average, hand hygiene practices lasted anywhere from 6.6 seconds to 21 seconds. And in 10 of those 14 studies, healthcare workers only performed hand hygiene for less than 15 seconds. And in 8 of those studies, it was less than 10 seconds. So even when we actually kind of start the process, we're not doing it very effectively, related to time duration as well as adequately covering all the surfaces of our hands and fingers effectively as we educate our healthcare personnel to do. So what about the environment? Well, there's been more and more literature and peer review articles and data being published about the role of the environment in transmission of infections. And this slide summarizes a little bit of what we know. We know that the environment does contribute. It's especially important as it relates to epidemiologically important pathogens like MRSA, VRE, and C. difficile. In one study, it was demonstrated that surfaces can be contaminated up to 25% of the time in a room. We also know that these pathogens live on surfaces for indeterminate periods of time, anywhere from days to weeks to months. And then it kind of makes sense that if the surface is contaminated and someone touches that surface, it can result in hand contamination. Again, we've mostly looked at healthcare personnel related to this. We also know if we clean that surface that we can reduce the contamination. And if we do clean or disinfect surfaces, that can assist in reducing healthcare-associated infections. And then, unfortunately, we know by some of the data that you're going to see here in a minute that rooms are oftentimes not adequately cleaned. So this is a study that was done in 2011 that demonstrated how well cleaning was done on daily cleaning versus terminal cleaning. So when the patient was still in the room versus after discharge. And you can see on the slide that there was only an average of 32% of the surfaces that they reviewed and looked at that were adequately cleaned. So that means 68% of those surfaces in the rooms, either while the patient is still there or even after they have been discharged, had not been adequately cleaned and disinfected. So what does that translate into? Well, recently there have been several studies published looking at the risk of a newly admitted patient to a room that had been previously occupied by a patient with an epidemiologically important pathogen. Again, the main organisms that were looked at were MRSA, VRE, and C. difficile. And what those studies have demonstrated is that admission to the room previously occupied by someone who was on contact isolation, so a patient on contact isolation was in the room, was discharged, the risk of the newly admitted person to acquiring that same organism ranged anywhere from 39 to 353%. For example, if the person in the room had C. difficile, was discharged, and a new patient was admitted to that same space, their risk for acquiring C. difficile was increased by 235%. So that's 11% risk versus 4.6 if the prior individual did not have C. difficile. So I think those studies bear the point very, very clearly that it's not just while the patients are in those rooms that there's some risk, but newly admitted individuals, that could be you or I or someone in our family that's admitted to those rooms, are also placed at risk if we do not adequately clean the environment. So in in summary about what we know, studies have demonstrated that 25% of healthcare workers' hands can become contaminated with C. diff spores after performing routine patient care. In this study, that was associated with either lack of glove use or some sort of fecal hand contamination, and that could have been if the gloves were used but taken off inappropriately and hands were not washed afterwards. Also, up to 41% of healthcare workers' hands were sampled after patient care and before they performed hand hygiene and were noted to be positive for VRE. So almost half of healthcare individuals who perform patient care and prior to hand hygiene, their hands were contaminated. Also, white coats, which could also translate to uniforms, can be contaminated. In this one study, they looked at grand round attendees. 23% of the time, their white coats were contaminated with Staph aureus, and 18% of those were found to be MRSA. And then, as we already discussed, environmental surfaces can also become contaminated, things such as bed controls, call buttons, and bedside tray tables, representing very critically important reservoirs for organisms and or pathogens. So this is a little bit about what we know, what the risks are. Well, are there some interventions and do they work? Well, this is a historical lesson that we're all familiar with, where in this particular OB clinic, there were two clinics, a first clinic and a second clinic. Dr. Semmelweis recognized that in the first clinic, mortality rates were significantly higher than in the second clinic, and the only real difference after looking at all factors was who serviced those clinics. And what he identified was that medical students who were also responsible for performing autopsies were carrying particles on their hands to the delivery room and to the patients that they were examining in the OB clinic. He was able to institute a policy of using chlorinated lime solution for hand hygiene and was able to lower that mortality rate significantly, almost down to zero. So we do know from a history lesson that hand hygiene does make a difference. Well, what about the current setting? Do we have any evidence that that's still true? Well, this is a article that was done here with our colleagues at UNC Chapel Hill. Emily and her team published this in September of 2016. And what they looked at was if they already had good processes for hand hygiene, but if they improved those rates, were able to significantly improve those rates, what kind of successes could they have with that? And what they were able to identify, they had 5 infection preventionists who looked at the infections according to the CDC NHSN definitions. And during this period of time of their clean in, clean out program, there were no other specific hospital-wide infection prevention goals that were adopted. And over the 17-month period, they saw a significantly increased overall hand hygiene compliance rate, along with a significantly decreased overall healthcare-associated infection rate, identifying 197 fewer infections occurred. And when they looked at it at the unit level, they found the same correlation with a 10% improvement in hand hygiene associated with a 6% reduction in HAIs. And then with C. difficile, they had a hand hygiene improvement with a 14% reduction in C. difficile infections. So not only do we have historical evidence that it makes a difference, but we also have current activities and knowledge that it makes a difference. So what about our visitors and patients? Does that make a difference? Well, I think up until now we've kind of looked at healthcare personnel as little mini pig pens, where everything, all of our issues and concerns and infections, we've tried to or have related to healthcare personnel. And for whatever reason, we kind of thought that our families and our visitors were good to go, and that we really didn't have to maybe pay quite as much attention to them. So do we have any data or any information that maybe we do need to focus a little bit more on that? And there has been, while limited, there has been some studies looking at this. One was done in 2013 where 100 hospitalized patients were looked at, and it was identified that 39% of their hands were contaminated at greater than or equal to 48 hours after admission. In another study published in 2019, looking at patients' hands and what's in their rooms, there was two hospitals in southeast Michigan recruited over 300 patients with 710 encounters or visits. And they looked at these individuals within 24 hours after admission to establish a baseline colonization and or contamination rate of the patient's hands as well as the environment. And then they followed them up on day 3, on day 7, and then again at discharge and weekly until they were discharged. And what they found is that at baseline, 10% of the patient's hands were contaminated with an MDRO. During their stay, another 6.2% of the patients had new acquisition. And then during the overall time period that they looked at anytime during their hospital stay, about 13.3% of patients' hands were contaminated. And then for the environment, surprisingly, or maybe not surprisingly, just under 30% of surfaces were contaminated within 24 hours of patient admissions. 21.8% had new acquisition, and then at any time, just under 40% were demonstrated to be contaminated with MDROs. They also were able to correlate a significant familiarity with the pathogens that were isolated from the patient's hands and the environment. In other words, they were the same, in most cases, were the same strain of multi-drug resistant organism. So there was another study done by critical care nursing, again out of the University of Michigan, recognizing that patients' hand hygiene was very difficult. They had a cardiothoracic surgical step-down unit. So they instituted a policy of placing alcohol-based hand rubs, very readily accessible to the patient. They provided them with education about hand hygiene, and they looked at their rates before and after and found that MRSA decreased, and these were infections, not just colonization. MRSA decreased by 63%, and VRE decreased by 70%. So that's pretty astounding and pretty impressive results. So those are our patients. Do our visitors actually wash their hands? Well, there have been some studies that looked at this. In one particular observationally controlled study, at baseline, they monitored hand hygiene of visitors coming in. They had an alcohol hand sanitizer mounted on the wall and a sign that said "Clean hands here." Their intervention, they got some baseline data of observations. They conducted those twice daily for a week at 2 different times to identify what their baseline would be. This was a 560-bed tertiary care center. And then their interventions were adding a sign mandating that all visitors use the hand sanitizer, another intervention with a freestanding hand sanitizer in front of the security desk, and then a combination of the freestanding dispenser and a sign. And what they found was that at baseline, and this sign was mounted, the hand sanitizer was right at the security desk, and everybody had to come in and sign at the security desk, so they had to stop there. And their rate of compliance was only 0.52%. With the mounted dispenser and sign. When they added this sign that you see, attention, all visitors must clean their hands, in bold font and red, it increased slightly, but only up to 0.67%. When they included the freestanding alcohol hand sanitizer unit, compliance increased to just under 10%. And then with a combination of the sanitizer unit and the sign, it increased to just under 12%. But that's still just very, very unacceptably low. So another study did the same thing, and I'm not going to go through these findings, but basically compliance in the main foyer. They looked at compliance in entry into the ward and then in access to the rooms, and their compliance actually was better in the lobby, but they had lots of visual clues. They had posters, they had signage, they had very, very big promotional activities going on in the hospital lobby, and they had just under 50% compliance. This was a study done out of Ireland. So there have been some folks looking at visitor compliance. And there's not been quite as much looked at related to visitors being compliant with transmission-based precautions. The Society for Healthcare Epidemiologists in America published their expert guidance on isolation precautions for visitors in 2015. And in that publication, they noted that there's not been any real published studies that have evaluated the impact of visitor adherence in reducing spread. And it does depend on the amount of time and the amount of contact. There were 5 studies that looked at compliance with contact precautions with visitors, but those were very small numbers, and most of those included healthcare workers as well, so it was very difficult to pull some real helpful data out of that. They did note that use of gown was the area that there was greatest compliance. And some of the reasons for non-compliance was lack of education. Families don't know what the sign means. They don't perceive the infection as a threat because this is their family member. They've already had prior exposure. It's convenient. And then some of the arguments that we in healthcare have used against requiring them to wear PPE is that they don't move between patient rooms. They limit their activities. It's difficult in education, and as we've already talked about, very time-consuming and difficult in enforcing compliance. So this is a survey that Shay conducted looking at trying to assess the policies related to isolation for visitors. Their response rate was about 21%, and what they found is that most of the education that was provided was done in the form of brochures or signs, but only 63% of those were done in English. Were done in English only, and then most of that education was provided by the doctor or the nurse. And this is just a graph of what they found. The requirements the same as healthcare workers, about 42%. Compliance monitored, about 21%, with precautions, and then with hand hygiene, about 21%. So again, even though they had the policy, 83% had a policy, compliance was very, very low. We found something very similar in North Carolina when we looked at our hospitals here. About just under 55% of hospitals surveyed had a policy, but of those that had a policy, less than 40% monitored or enforced compliance. So I guess one takeaway from that is if you've got a policy, make sure that you have some methods of monitoring compliance with that policy. So we do know that visitors have been related in outbreak situations, tuberculosis in pediatric patients. We've seen that those implicated in norovirus and influenza. And then in SARS, clearly there was a cycle of visitors part in that transmission cycle. So we know it does make a difference, particularly in outbreak settings. So what is the guidance currently state? SHEA says that all visitors should perform hand hygiene. For endemic situations with MRSA and VRE, they actually do not recommend contact precautions. Contact precautions should be considered when the patient is colonized or infected with some of the novel or the extensively drug-resistant organisms like CREs. And then contact precautions should be used by visitors if the patient is infected with enteric pathogens like C. difficile and norovirus. And then they had some additional information in there about if the visitor is like with a pediatric person or someone that's going to have an extended stay, trying to institute isolation precautions may not be practical. If they're on droplet precautions, they should use a surgical mask. And then in situations where heightened horizontal transmission is detected or in an outbreak setting, then all visitors should be prioritized and should adhere to isolation precautions. So what's the lessons we've learned? We know that horizontal transmission does occur via the hands of healthcare workers and potentially the attire. We know that visitors do have a role in horizontal transmission as well, but it's not clearly defined like it is for our healthcare workers. Also that community-associated resistant strains of organisms may be spreading throughout our healthcare system, and that the need for hand hygiene compliance among healthcare workers has been clearly demonstrated. But to date, we don't have really good studies to show that that's equally important for hospital visitors, although I would argue it's really just common sense. So where do we go from here? Well, really, I think that we as a healthcare team need to come together and really look at this from a multidisciplinary approach. And I went to a meeting in Chicago last week where they used the term a day of innovation versus a meeting. It gives a little bit better context as to what we're here for. And I think one of the first steps you would want to do is look at what precautions, which organisms you're going to institute precautions for families and visitors for. Decide if applying the SHEA recommendations is appropriate for your setting, and you'll do it for C. diff and some of the novel organisms, but not for MRSA and VRE. And then develop educational campaigns that include, based on the data, visual, verbal, and written cues. Consider modifying those formats about every 3 months and give them some new information. And most importantly, monitor initially to have information for a baseline to compare to. And if you can, compare that to your surveillance data, so your compliance data and your surveillance data at baseline. And then with whatever intervention you opt to go to, monitor that and see if you can correlate with your surveillance data, and if you've made a difference or if you need to go back and rethink or re-strategize what your plan is. And I know we're really out of time here. We wanted to leave a few minutes for questions, but I think these pillars do make a good point. Everyone serious about success is really serious about teams. So I would leave you with that thought that get a team together, look at what's appropriate for your organization, make sure your policies and protocols and procedures marry that, and most importantly, monitor your intervention to determine if it does make a difference. And so with that, Shelby, I think hopefully we have about just a few minutes if there's some questions.
We do, Evelyn. Thank you so much. This was great information. And you have a couple of options for asking questions. You can type your questions into the control panel, into the chat box, or you can raise your hand. And you can raise your hand by going into the
your control panel. Mm-hmm. And you can click the hand icon, and we can unmute your line if you choose to ask your question out loud.
And we do have one question, Evelyn.
Okay.
What does the term endemic mean in terms of isolation not needed?
That's a great question, and basically that means endemic is when, it's pretty commonplace within your organization. So we have two terms. Endemic is kind of recognized that we see it, and most often that's like MRSA and VRE. And then epidemic means either that you may be having an outbreak or it's an unusual organism that you have seen, maybe not for the first time, but you have rarely seen it. So for endemic, it's like you're throwing up the surrender flag. We know we have it, and standard precautions should be enough to interrupt transmission with those. So while MRSA used to be our major source of concern, that organism's certainly been replaced by other organisms recently.
Thank you, and thank you for that question, Bonnie, from Novant Health. Other questions? And while we're waiting for someone to raise their hand or chat in, Evelyn, I have a question. What have you seen the biggest challenge to be in the facilities that you've worked with around patient and visitor compliance to hand hygiene or transmission-based precautions?
So that's a great question. I think it really summarizes the webinar today. The biggest challenge is multifocal. I think it's time to adequately educate the patient, the family members, and the visitors when that interaction first occurs, to start initiating that rapport. So I think it is a time issue. I think it's a method issue. If we just give them a brochure and don't follow that up with, do you have any questions or do you understand that? Visitors and patients are still reluctant to ask a lot of questions because they don't want to look like they don't kind of know what's going on. And then I think all the things that we mentioned in the presentation. I mean, visitors, I took care of my mom at home. I didn't wear a gown and gloves. Why do I need to do that here? So I think it's very multifactorial, Shelby, and so I think that's why it's very important that we need to have a clear pathway of where we want to go. What organisms are we going to do this for? How are we going to structure that education? When and where is it going to be done? Who's going to do it? How are we going to reinforce it? And then how are we going to monitor it? So it is a challenge. The one thing I would say again, if you are not going to monitor or enforce it, you might want to reconsider whether you have that statement in your policy that visitors and families will adhere to your isolation precautions.
Evelyn, thank you. Those are important points. And this leads right into the next question being asked by Keith Lewis. Can a facility be cited for a visitor failure to follow precautions?
So I think the surveyors, whether it's CMS or Joint Commission, are certainly going to survey you based on your policy. So, and that's why it's so important to look at that in your policy. If you have it written that they are going to conform to those policies, then I do believe that you probably would be cited for that. If you do not have it in your policy, there may be some discussion with the staff. I can't really speak to how surveyors would do that, but I think they would be less likely to cite you if it was not spelled out in your policy. I think they will definitely hold you to what your policy says.
Thank you, Evelyn. We have another question that's come in we may need some clarification on. This is from Sandy Neola. And Sandy asks, with patient contamination of hands and environmental contamination, what are your thoughts about removing food trays from isolation and glove use?
So, that's a great question, and it's it's one that comes up a lot. I mean, trays, we've not been able to demonstrate. We know, yes, can they become contaminated if they're in an environment where, we know the environment's contaminated, that bedside table's probably got organisms on it, the patient's hands. So there is some potential contamination. We've never quantified any risk of transmission with that, however, and it's kind of like taking a pen or a pencil into one of those rooms, so that whole interaction is very short in nature, where the tray is actually in the room. And then if the person is on full isolation contact precautions, for instance, according to the recommendations, you do have to wear gown and gloves when you go in to retrieve that tray. I do not know of any recommendation, nor do I recommend that dietary workers wear gloves when they go in and remove a tray. Certainly, it's very important to perform hand hygiene after they pick up the tray and place it on their cart. But I'm not aware of any recommendation, unless the person's on isolation, to use gloves when retrieving dietary trays.
Thank you, Evelyn. We don't have any further questions at this point in time, but if anyone on the call has additional questions that you would like to have Evelyn answer, you can email me at slassiter, Lassiter, @NCHA, and I'll pass those on to Evelyn and try and get a response for you. Please go with our thanks today for being with us, and take this information and share it throughout your organization. And we have a question: is this presentation being recorded? It is, and we will be posting this and the PowerPoint to our North Carolina PSO website. It will be in public domain, as there's no confidential information in this presentation, so we will be sharing it. So with that, we are at time. We'll go ahead and close today's presentation. And again, Evelyn, thank you so much for sharing your tremendous amount of knowledge and expertise with us today. And thank you all for being with us. Have a good afternoon. Bye-bye.
Bye-bye.